Greetings, everyone. Please note that we are recording these sessions for later distribution through the Chagas Echo website. We are excited to have all of you join us today for the Chagas Echo series. My name is Kato Kawasaki, and I am with the UT Health San Antonio Echo Super Hub. I just have a couple housekeeping announcements before I pass things over to Dr. Stigler Granados to continue with the introductions. Thank you, Shreya. Here's our agenda for today. We'll start off with some introductions and announcements, then move on to presentations by Dr. Forces and Dr. Wheelock, with time for Q&A. During the session, please stay muted unless you're speaking, but we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls, or if you've joined by phone, just press *6 to unmute. You can also use the reactions menu to raise your hand, or you can use the chat to ask questions. And answer questions and share any perspectives you may have anytime during the session. And finally, please note that no protected health information is allowed in either the chat or our discussions. The session is, next slide, please. Thank you. The session is brought to you by the Rockefeller University Clinical Directors Network, Texas State University, San Diego State University, and UT Health San Antonio Echo. And our Echo Hub team members are listed here. Next slide. The topic of discussion today is Chagas disease as a migrant health issue. This is session 3 of the 4-part series. In case you missed our last 2 sessions, you can visit our website to view the recordings. We will drop the link to our Chagas Echo webpage in the chat momentarily. Also, we will be offering continuing education credits for providers and nurses at 1.5 hours CME credits for each session. Towards the end of the session, we will send out a link to an evaluation survey. Please fill it out to receive free CME or CME credits. And I will pass this over to Dr. Stigler Granados.
Thank you, Kato. Good morning, everyone. Welcome to our Echo session this morning. I'm really happy to have you all here. We have quite a few people still logging on. Please be sure to put your name and your affiliation, if you have one, in the chat so we kind of can keep up with who all is here. So I'm super excited. This is the 3rd of our 4-part series that we have been doing in collaboration with Clinical Directors Network. And there's some more information here on the slide about our funding and about their funding and how we put all of this together. I especially want to thank my partners in CDC, Dr. Sue Montgomery, and our Chagas Disease Cooperative Agreement for helping to fund our Echo sessions all of these years now. And we're very excited to be partnering with Clinical Directors Network on this as well. Next slide. This is a little bit more information about CDN. So they're a New York City-based practice research network and an AHRQ designated center of excellence for practice-based research and learning. And they're also a network of safety net PBRNs dedicated to improving access to care and clinical outcomes for low-income and medically underserved communities by creating community academic partnerships around research, education, training, and service. And this is why we've always felt this is a great partnership for us, because as me coming from an academic institution, our focus is really, especially with Chagas disease, to try to get this out there into the primary care clinics and community, and especially that Chagas disease is a disease that affects mostly lower income and medically underserved communities. Next slide. I'm very excited to present a very wonderful colleague, Dr. Colin Forsyth. Him and I have had the pleasure of working together for several years now, and I'm very honored that he was able to join us today to talk to us about his experience and knowledge in Chagas disease. And I'm just going to read a little bit about him on this bio, but he's an epidemiologist and medical anthropologist. He lived in Bolivia in the 90s and became acquainted with the devastating impact of Chagas disease while there. He returned to Bolivia in 2013 to complete his dissertation research focused on the sociocultural dimensions of Chagas disease in Bolivia. In 2016, Colin also joined the DNDI to perform Drugs for Neglected Diseases and Initiative to perform qualitative and epi research on barriers to access to diagnose and treat Chagas disease. He's conducted research in Bolivia, Los Angeles, and in the whole United States, basically investigating the beliefs, experiences, and treatment strategies of people affected by Chagas disease, as well as key barriers that hamper access to healthcare. Colin is also involved in multiple projects to improve access to diagnosis and treatment, and manages DNDI's Chagas Clinical research platform. And Colin also doesn't say this on here, but he helps lead many of us Chagas researchers across the United States and across the world in several initiatives, and keeps us all together and talking about Chagas disease and what are these barriers. So we're very grateful to have him here and always grateful for his championing of this very important topic. And I think my colleague, Dr. Zhu, is going to present the next presenter.
Hello, everyone. So we are very privileged also to have Dr. Alice Wheelock talking to us about Chagas disease. So Dr. Wheelock is a postdoctoral research fellow and infectious diseases physician at Boston University, a School of Medicine at Boston Medical Center. She completed internal medicine residency and infectious diseases fellowship at BMC, where she currently attends on infectious diseases in inpatient service and in the Immigrant and Refugee Health Center. Her work on Chagas disease includes research on local diagnostic testing, as well as educational programs to encourage screening for Chagas disease in people from endemic regions. So we welcome you, Dr. Wheelock.
Thank you. And I will be facilitating this session. Many of you we've probably met, but just a little bit about myself. I am an associate professor in the School of Public Health and the division head for our environmental health division at San Diego State University. I have been working on Chagas disease for about the last almost decade through a Center for Disease Control cooperative agreement that I mentioned earlier. And the goal of this project is to educate healthcare providers on Chagas disease in the United States and help improve awareness around this disease. I work a lot with our US military population on Chagas disease surveillance activities, and I helped to launch the Texas Chagas Task Force back in 2015, and it's also sort of become now the US Chagas Task Force. So I'm very happy to be here, facilitate this session. Please, as a reminder, this is a very interactive session. We would love to hear from you all. Please feel free to put your comments in the chat, and we'll also have time for discussions. So here's a couple of reminders. Thank you for changing the slide. So use the Q&A to ask questions, and be sure to complete the evaluation upon exit. That really helps us. Also, if you're getting CME or CEUs, we need your evaluation in order to process those credits. We will record this session. We post it on the UT Health website, who sponsors this ECHO, as well as CDN is posting it on their website, where you can go and watch it again or send it to colleagues to watch to get CME for watching the recorded session. I think that's it. This will be a link to the evaluation at the end. So I think we're ready to transition over to, oh, we have one announcement. There's going to be probably several World Chagas Days events going on, but just as a reminder, International or World Chagas Day is April 14th every year, and Sun River Health is sponsoring an event from 11 to 3 o'clock Eastern on April 12th. And we will have, if you want, we'll put this link in the chat. I think we can do that as well if people want to register for this event as well. I think this will be the last slide that we end with, Kato. You want to switch over. So with that, I'm going to introduce or have Colin and Elise take over for us. And thank you again so much for being here.
Thanks very much, Paula, and to everybody who's organized this event, and for the invitation and the opportunity to be here. Let me just share my screen. There we go. Okay, so our topic today is Chagas disease as a migrant health issue, and just to go over some of the objectives that were established for today. Understand why Chagas disease is a challenging global issue, explain how Chagas disease impacts groups of people in different ways, and what are strategies we can use to mitigate the types of problems that Chagas disease causes for migrant communities. So in the first part, and Dr. Wheelock and I will be switching back and forth. But in this first part, we're going to talk a bit about the global context of Chagas disease and migration, at least as we've traditionally been looking at it. And then later on in the session, we're going to kind of put that into a more recent context. So this is a map which just sort of shows the global extent of Chagas disease. And it's hard to differentiate here, but you can see in dark gray the countries that are traditionally considered endemic, ranging from Mexico to the southern cone of South America. Note that this is mainland Latin America. The Caribbean is traditionally not considered endemic. And of the countries that are pictured in different colors, these are areas where there are communities of people from the Latin American diaspora. So communities of people who acquired the infection in Latin America and are now living in other countries, and in most cases don't know that they have the infection. The United States has a really unique situation in that we do have vectors capable of transmitting the disease, and we do have locally acquired cases, but the majority of people living with the infection here acquired it in Latin America. And this is just a graphic that kind of represents the global burden and problems we're facing with controlling Chagas disease as a public health issue. So if we put all the estimates together, there's a little over 6 million people infected with T. cruzi, which is the pathogen that causes Chagas disease. And of those, a little over 2 million would probably not have an indication for antiparasitic treatment for various reasons, such as advanced age, or because they already have an advanced, they're already in an advanced phase of the disease. That leaves about 4 million people worldwide who could possibly benefit from antiparasitic treatment. And to the best of our knowledge, out of this number, still less than 500,000 people have been diagnosed, which represents under 7% of the total. And even fewer of those have been treated, so about 1% of the total. Now, these numbers could probably use updating, but still, this gives us a good indication of what the picture is right now. So we're in a situation where almost everyone who has the infection has not been able to access treatment. And this is the situation in the United States right now. So according to the most recent estimate, there are around 288,000 people living with the infection who acquired it in Latin America. And as I mentioned, we also have local transmission, which is rarely documented. We definitely need more research to understand the extent of it. But in this recent paper, which is cited at the bottom, they estimated that up to around 10,000 people might have acquired it locally here in the United States through our vectors. What we do know is that less than 1% of this number has been diagnosed and treated. And the estimate also suggests that there's over 50,000 people who are living with cardiomyopathy due to Chagas disease. And again, just to reinforce that across the southern half of the country, and increasingly, we've had documentation in states where the vectors weren't seen before. So we do have vectors capable of transmitting the disease as part of our natural environment. What are the main risk factors for Chagas disease? What consistently comes out in the literature? First of all, just having lived in an endemic country in Latin America, again, excluding the Caribbean, and having lived in housing that's made of natural materials, such as adobe or thatch in a rural area of Latin America, and having a family member with Chagas disease, as well as finding kissing bugs living in the home, especially the nymphs, which indicates that there's a reproductive cycle of the vector going on in the household. There have been several studies on the ground to sort of confirm the numbers in the estimates, which I showed earlier. And a couple of them have been community-based studies in Washington, D.C., in Boston, and in Los Angeles. And you can see the prevalence in those three studies ranges between 1 and 3.8%. It's a little higher in the DC area because of the makeup of the population, where you have a large Bolivian community. Other studies have looked at the prevalence in family members of patients diagnosed with Chagas disease, and you can see it was very high, over 7%. And finally, hospital-based studies have looked at the prevalence in people from endemic countries who have gone for other reasons and have found a pretty high prevalence in those groups as well. And just to mention also that in another study, we found that people who are living with T. cruzi infection oftentimes are also dealing with other comorbidities. And so in this study at the Center of Excellence for Chagas disease in Los Angeles, over 50% were living with 2 or more chronic comorbidities, and the most common were hypertension, obesity, hyperlipidemia, and diabetes mellitus. So why is Chagas disease of special concern for migrant communities? First of all, people who migrate from Chagas endemic countries, they're often migrating because of the socioeconomic conditions and the marginalization that they're experiencing in their home countries. And this is precisely one of the risk factors for Chagas disease as well. And then when they get to host countries in the United States or Europe or elsewhere, access to healthcare is often quite precarious. Even in countries which have universal systems of care, migrants are a group who often fall through the cracks. And another area, now this is going into the realm of speculation a little bit more, but it deserves more research, is whether migration itself exposes people to T. cruzi. We know that the migration journey entails a lot of potential health risks, but more research is needed to determine whether there's a relationship with T. cruzi exposure. We'll talk about that a little bit more later. There have been some studies of prevalence studies which occurred among people along migration routes. So for example, one study along the Mexico-Guatemala border of a sample of migrants found that many had reported seeing triatomines at places that they slept during their travel. 12 were actually seropositive for T. cruzi. And in another similar study, half of the sample had reported being bitten, and 20% had serological evidence of T. cruzi. And now we come to our first poll question, which I will put it up there. And the question is, which of the following individuals would you expect to have the lowest risk of Chagas disease based on the information I just presented? And I'll give just everybody a minute or two to answer that. Okay, looks like that's going pretty quickly. And yeah, the majority of people chose Wilson, even though he fits the profile of being from a rural area of Latin America, with Puerto Rico being in the Caribbean. It hasn't been considered an endemic area for transmission of T. cruzi. So he'd be the one person that, not that he couldn't have been exposed at a different point in his life, but just based on the information we have here, we would expect him to have the lowest risk. Even though Mario was born in the US, his mom is from Bolivia, so it might be interesting to test his mom first of all. And if the mom had T. cruzi infection, there's always the possibility of vertical transmission. And everyone else also is fairly young. So they'd be, a priority of a person who could benefit from getting screened. And let's see. At this point, I'm going to turn it over to Dr. Wheelock.
Great, thank you so much, Colin. Can you hear me? All
Yes.
right. Excellent. So throughout this presentation, I'm going to be weaving in some cases and vignettes and examples to sort of solidify a lot of the messages that we want to communicate during our presentation. And these examples come from where I practice as an infectious diseases physician, which is Boston Medical Center, which is a large academic safety net hospital in Boston. We follow in the infectious disease clinic a panel of over 120 patients with Chagas disease, most of whom were diagnosed by screening either at Boston Medical Center or at a local community health center called East Boston Neighborhood Health Center. So we can go to the next slide. The first story that I'll share with you is really to highlight more of the clinical context of why we care about this disease and what can happen when this disease goes unrecognized. So this is a 42-year-old woman who was previously healthy and is from El Salvador. She was later seen in the infectious diseases clinic, but she had noted that she had a history of stroke at quite a young age in 2014 in El Salvador. And she works at McDonald's and was unable to take a lot of time off for appointments due to her manager, who is very strict about taking time off. So prior to the events that unfolded, she really didn't have a lot of connections to the medical system. And then in 2019, you can progress to the next slide. She had sudden onset complete Broca's aphasia and right-sided weakness while she was at home with her family. And she was rushed to the emergency department and became very connected with the medical system at this point. Her subsequent workup included neuroimaging that showed a left MCA stroke that had led to the Broca's aphasia. And she had a transthoracic echocardiogram, which showed a normal ejection fraction of 55%, but revealed a left ventricular apical aneurysm and a kinesis of the infralateral and anterolateral walls with an associated thrombus, which was thought to be responsible for this stroke. And here's a representative photo of her echo. On further workup, she did have testing for why this had occurred, and her T-Cruzy serologies were positive both on the initial screen and the confirmatory testing. Subsequently, she received a lot of acute rehab with physical and occupational therapy. She was started on anticoagulation given the thrombus, and she was later evaluated in the infectious diseases clinic. Unfortunately, she was not thought to be a candidate to benefit from antiparasitic treatment for the reasons that Colin mentioned, that given end-stage organ involvement of this disease, there's evidence to suggest that antiparasitic treatment is not effective at that point. So fortunately, her right-sided weakness has resolved, but she still has some speech difficulties that persist. And I share her case as a young, previously healthy woman who's already rather stretched thin in regards to her safety net and her financial and employment situation. Experiencing this devastating stroke, I think, is a wake-up call as to what this disease can mean in people's lives and why, as physicians caring for a migrant population, it's important to think about. So by way of some review of information that was shared during the first session in this series of talks, what we understand of the natural history of Chagas disease is that it starts with the acute infection from the T. cruzi parasite and then transitions into this chronic phase that starts with an indeterminate form with no signs or symptoms, a normal EKG. And then in a subset of patients, which is estimated to be somewhere between 20 or 30% of patients over the ensuing years to decades, a determinant phase will develop. And in some, this is cardiomyopathy with or without GI disease. So in terms of the cardiac manifestations of this disease, this is a very arrhythmogenic disease. You can see cardiac arrhythmias that range from heart blocks to sinus bradycardia, all the way to fatal ventricular tachyarrhythmias. Conduction abnormalities are also very common in the cardiac phase of this disease. And in particular, the textbook example is a right bundle branch block. Myocardial abnormalities can also be seen, and the dilated cardiomyopathy that develops is a hallmark of Chagas cardiomyopathy. And aneurysms, especially as in this patient in the left ventricle apex, are also somewhat more specific for Chagas cardiomyopathy. And as a result of all these factors, there is an increased risk of thromboembolism in patients who would otherwise be considered young and healthy. So going back to this natural history, we really want to intervene with treatment during the indeterminate form before development of cardiac disease. We know from the BENEFIT trial, which was a large international randomized control trial comparing placebo or benznidazole for patients who already had established cardiac involvement, that unfortunately there's no evidence for clinical benefit at that point in time. And so I think this is a reason why we really emphasize the importance of screening patients, even those who don't have symptoms or EKG findings that make you specifically think of Chagas disease. So again, we'll pause here for another poll question. So if you're seeing a patient who is from El Salvador, who has been diagnosed with Chagas disease and has not returned to El Salvador for the last 20 years, what are some potential objective findings that could be seen in this patient? All right. Let's see what the poll responds. Yes, so most people responded any of the above, and this is correct. I think that regardless of how long ago it's been that somebody migrated to the United States, they may show various signs of Chagas disease, anywhere from the indeterminate form to some of the more advanced cardiac signs of disease. And I think it's important to remember, even in those patients who may have lived in the United States since childhood, and you wouldn't necessarily know their background of where they came from, that this is a consideration.
At this point, I'm going to talk in a little more detail about some of the barriers to care impacting people with Chagas disease. And I think, you know, Dr. Wheelock's story really brings a lot of these into a real perspective. So this is just a framework to sort of help us think about, you know, the different kinds of barriers that are making it difficult to expand access to testing and treatment for Chagas disease in the US and elsewhere. So I'm just going to start in the sort of the bottom left here with the clinical barriers. And these are the things we usually think about. And these are just limitations in our knowledge and in the tools that we have available to care for patients. So for example, right now, we don't have a good test of cure to know, the full impact of treatment. We have differences in the performance of some of our diagnostic tools, depending on where patients are from. We have side effects from the medications that are available to eliminate the parasite, and so forth. Systemic barriers have more to do with gaps in the way that the health system is currently organized that limit our ability also to care for patients. And so this can cover things such as, not a lot of time or attention is devoted to Chagas disease in medical education. Sometimes it's considered sort of an exotic imported disease rather than something we have right here in the US. There's not a lot of tests that have FDA clearance at our disposal. And also it's a very difficult disease for example, for manufacturers of tests, for manufacturers of medication, because most people don't know that they have the infection. And because of all of these different barriers, the demand is permanently low. So it's challenging from a health system perspective. And then going over to the structural barriers, these are gaps that have to do with socioeconomic inequalities. And so, for example, Aliza's story about, a woman had difficulty in getting to appointments because she can't get time off from her job at McDonald's. So this is just an example of how her socioeconomic condition makes it very difficult for her to start treatment for Chagas disease. And this is a common type of story. Psychosocial barriers have more to do with the impact of the disease on people's emotional lives. So for example, stigma at having this kind of infection, which is often associated with poverty and rural conditions in Latin America. And also the diagnosis of Chagas disease can be very traumatic for some people. And when you consider that migrants are often people who are dealing with a host of challenges in their lives, as well as potentially other health problems, sometimes having to take on one more thing is a lot to ask. We're asking people who feel okay to get tested to know then that they have a life-threatening disease. And some people simply prefer not to know, and to take an attitude of when my time comes, it comes. But if I know that I have this, I'm going to worry about it. It's going to deteriorate the quality of my life. Awareness is a big problem, not only in the community of people at risk for Chagas disease, but also among healthcare providers. So one survey of Latin American-born residents in Los Angeles, for example, found that 86% had never heard of Chagas disease before. We've seen similar results in other studies. And then here, I've changed the names, but just a couple of quotes from patients kind of indicating how this plays out and how this makes them feel. One says it's a fatal disease, yet you don't hear anything about it. It's like a phantom disease that is killing people, but nobody knows it exists until they tell you you have it. You always hear about diabetes, cancer, but Chagas is something that's never heard anywhere, not even in the media. So this makes people who are diagnosed feel isolated, and it also can make it very challenging for them to talk to others about it. And another person said the majority of doctors in the United States don't know what Chagas is. I've gone to 2 cardiologists, and I had to show the doctor on Google what Chagas is. And again, this is a common type of story we hear. When we asked people with the infection what their main difficulties or concerns were in terms of being able to get to see a doctor for Chagas disease, the most common reasons that were listed were not having transportation, difficulty in getting time off from work, as we saw, lack of insurance coverage, not having financial resources, bureaucracy, delays in being able to access the health system, and not having services close to home. And here's kind of an example that demonstrates this. One person said, before I couldn't go to the doctor because I didn't know how to drive. I had to wait for someone to take me. I depended on someone giving me a ride as a favor, and then I didn't have money to pay for the appointment or the ride, or sometimes for lack of time, and I've had to neglect other tasks so I could go to the doctor. Then in terms of, what are the difficulties that people with Chagas disease in the United States are facing in relation to their migratory experience, I think some of the top challenges were the language, not being able to communicate. And this is especially important when you think of being able to communicate a complex and not very well-known disease like Chagas. Being far away from their families. So as Elise mentioned, not having a support network, and being able to find and keep jobs. And again, here are a couple of quotes indicating how people felt. The first person says, that they go about in fear because of their documentation, and also not being able to speak the language just compounds that fear. And the second person talks about the difficulties they had in finding and keeping jobs. And then because of Chagas disease, couldn't go to work because they were constantly in the hospital. So it's important to remember, that as healthcare providers, the focus has to be on the biomedical or the physical dimensions of the disease. But the person who is diagnosed is also experiencing an emotional impact, and potentially they're experiencing impacts in their social life as well. So really, ideally, we need to think of solutions that address all these different aspects of the impacts of Chagas disease. So what are some of the key challenges we're facing in organizing programs to care for migrant communities in the United States who are impacted by Chagas disease? First of all, we have a heterogeneous Latin American population. So we have people from El Salvador and people from Argentina living here who need to be tested. And what we've been seeing is that these populations seem to have differential responses to testing and treatment. We still need a lot more research to find out, how important that is and why that is. But it is a factor that has to be taken into account. Also, strategies around information, education, and communication need to be adaptable enough that they can appeal to all of these groups. So just taking a basic thing like the name of the kissing bugs, there seem to be different names in all of the countries. So in Argentina, they say vinchuca, in Brazil, barbero, in Central America, chinche, besucon, and different terms. So all of this has to be taken into account. Finally, availability of insurance coverage. So if we're going to test people, who is going to pay for their care? And while the antiparasitic treatment is relatively inexpensive, some of the complications that we saw can be quite expensive, such as heart disease. Linguistic differences between people at risk and healthcare providers. And also in this community, there can be a lot of fear of accessing healthcare, especially with a lot of the rhetoric centered around migrants using healthcare. Inability to get time off from work, again, challenges in transportation. Also, we're talking about a population that can be mobile in some areas. In some places, migrant communities are well established, but in other places, people are moving, either going back and forth to home countries or going to different parts of the United States for work opportunities. As I mentioned, people preferring not to know that they have the infection can be something that makes it difficult to get people screened. And just a general desire, even not only for undocumented migrants, but even for people who have legal status, just to stay under the radar and not make any waves, so as to not put their status in jeopardy. And shifting gears a little bit, also every state has a different dynamic. And this is just a table that kind of compares some of the differences between the 4 states that are estimated to have the highest number of people with Chagas disease: California, Texas, Florida, and New York. So you can see the estimated numbers of people with the infection, the estimated Latin American populations in each state. And also it's important to mention the composition of those populations is different. So in California, we're talking the majority coming from Mexico and Guatemala. In Florida, you have a different mix. You have a lot of Cubans and Puerto Ricans. The percentage of the Latin American population that is foreign-born. So again, this can help us sort of estimate the number of people who might need screening for Chagas disease. Texas is the only one of the states that has an experience with Chagas as a reportable disease. Most of these states have local vectors capable of transmitting the disease, except for New York. And 2 of the states, Texas and Florida, did not adopt expanded Medicare. And as you can see, the uninsured rates are different accordingly. And the number of patients in the last row, now this could probably be updated now, but still very low compared to what we would have expected. So this brings us to our next poll question. Which of the following is a false statement about the key differences between California and Florida that impact programs for Chagas disease? So I know I went over that a bit quickly, but I'll give you a minute to think it over. And remember, we're picking out which one is false, which one of these is not correct. All right, it looks like everybody has pretty much been able to get it. So yes, the majority answer here was correct. Actually, both states do have vector species present in the natural environment. The one state that did not, among those that I showed, was New York. So really in the southern half of the United States, east to west, there are vectors capable of transmitting T. cruzi. And actually have one more. Which of the following is not a major barrier affecting access to diagnosis and treatment of Chagas disease? So I tried to make it harder by switching up the wording, but it looks like it was still too easy. But that's correct. These are all examples of barriers that affect access right now. And we could go on for a long time about the different barriers. At this point, I will pass it back to Dr. Wheeler.
So to build off the discussion of barriers, I'll be talking a little bit about supporting individuals through Chagas disease treatment and care. And the vignette I'll share here is just to underscore that these barriers don't stop once you get people in the door with a diagnosis of Chagas disease, that they continue to shape the experience for patients and how we need to step up to provide care. So this is a patient in our ID clinic who is a 35-year-old woman from rural El Salvador. She moved to the United States in 2010, and she was found to be to screen positive for Chagas disease in 2018. She was screened through the Strong Hearts program, which is the screening program for Chagas disease run out of the East Boston Neighborhood Health Center. She's a single mom of 2 children, aged 6 and 12 years. So already, a lot on her plate. And she works preparing food carts for commercial airplanes. So she is really stretched quite thin. Fortunately, her EKG just showed sinus bradycardia, and her transthoracic echo was normal. And so in her infectious diseases evaluation, she was offered antiparasitic treatment, which was a 60-day course of benznidazole. So I'll stop here to mention that I think one of the direct outcomes of Chagas disease being a neglected tropical disease is that the treatment options are rather nasty for patients. The 2 treatment options are benznidazole and nifurtimox, and both of them carry a pretty intense side effect profile. So as a result, in our infectious diseases clinic, we do a lot of monitoring and checking in and sort of wraparound services during the treatment phase. So for this patient, she had visits on day 1, 15, 30, 37, 45, and 60 of her benznidazole therapy. 3 of these were over the phone, led by our former pharmacist, Alejandra Salazar, who's a Spanish speaker. And in addition to the doctors and Alejandra and who were treating her during these visits, there's also a patient navigator who helps with things like reminders for the appointments and making sure that people have a way in and scheduling follow-up and so forth. She attended these visits. She did experience some adverse effects of the medication with a mild pruritic rash that started on her arms. She had some daytime fatigue, and she had nausea throughout the treatment course and vomited 3 times. So adjunct medications were prescribed. The hydrocortisone cream helped her with the rash that spontaneously resolved on her arms. And for the nausea, she was prescribed meclizine to be taken 30 minutes before each of the benznidazole doses, which helped her to get through this treatment. And so in follow-up, she was able to complete the 60-day course of treatment, and she continues to follow once a year in infectious diseases clinic. She continues to be asymptomatic and has a normal EKG. And her children were both screened and screened negative. So from her case, I think the good news is that with the right support, we can help people get through this treatment, but the treatment remains very difficult for patients.
Thanks. And in this section, I'm going to talk about some potential strategies to help improve access to testing and treatment in migrant communities. So, and I like to highlight, there's lots of different people around the country, including Boston, who are doing great work on Chagas disease. Really, there are local champions who are carrying the flag. In the picture here, you can see Sheba Maimandi, who was one of the early pioneers in this at the Center of Excellence for Chagas disease at Olive View UCLA Medical Center. And so just wanted to share their experience. The UCLA Medical Center, the Olive View UCLA Medical Center is a safety net facility in Los Angeles. And most of the patients who were referred for Chagas disease, many came from a community-based screening program that Dr. Maimandi organized, relying a lot on volunteers who are often medical students from endemic countries, referrals from Red Cross, so people who were donating blood and found out that way, screening of patients in different areas of the hospital, referrals from family members of patients who were previously diagnosed, and just inquiries from patients and providers in the LA area and really throughout California as the work came to be better known. And so in their experience, they've screened over 8,000 and treated over 300. And interesting to look at some of the dynamics of the patient population. Most have lived in the US for over 20 years. So this is a pretty well-established community. Despite that, the majority are living below the federal poverty line and don't have a high school diploma. And most are able to access care, thanks to the availability of local programs such as Medi-Cal and My Health LA, which are state programs that help vulnerable communities get health care. Along with Dr. Memandi and many others around the country, we have worked on developing recommendations to make it easier for people to make it easier for healthcare providers to understand how to provide testing for Chagas disease. And so in this graphic here, it's just kind of illustrating the process that has to be taken, which is not always straightforward. We can't confirm diagnosis with one test, so it takes 2 to 3 tests. And again, here I've highlighted the risk factors that were identified. So if you see these factors in the history of a patient, they're a good option for screening for Chagas disease. And this, I've put the reference here, this publication is open access and available to anybody who needs it. And this is just a kind of a long table from another publication that's just putting recommendations on what actions need to be taken to improve access to testing and treatment. And as you can see, the symbols here are just to highlight which of the different barriers in the multidimensional diagram I showed earlier would be addressed through these actions. So first of all, incorporating routine screening, diagnosis, and treatment of Chagas disease into primary healthcare programs. And one goal of the screening recommendations was to try to make that easier for people. Regulatory approval of more diagnostic and therapeutic options, incorporate Chagas disease knowledge and treatment guidelines more into medical school curricula, develop affordable medications that are safe and effective in all phases of the disease. As Elise mentioned, there's an important segment of the population for whom the current treatment is not recommended. Explore means of reducing side effects and maximizing efficacy in the current treatments, as well as we need other treatment options. Create simplified diagnostic procedures to minimize discordant and inconclusive results. We need an accurate test of cure and biomarkers which reliably predict disease progression. And important for our discussion, we need programs which offer free or low-cost services, including transportation, and provide healthcare in environments where patients feel safe. So Dr. Memandi's program, and I know the program in Boston. There's another program run by Dr. Norm Beatty in Florida. And one thing that they do in common is they try to provide testing in a safe environment. So thinking about churches, community centers, places where people feel safe from persecution due to their immigration status. I think it's also important to link CD programs to other community-based services for migrants, especially when we consider, sort of about the universe of other problems that people are dealing with. Integrating mental health services into healthcare for Chagas disease at the point of diagnosis, because it can be a traumatic diagnosis. Another interesting thing, which is really being championed by Dr. Beatty's program in Florida, is bringing in, screening for chronic diseases as well. We should really be offering a whole package, supporting the development of patient groups and associations. That's very challenging in the context of a migrant community, but I think it's something that's important for patients to have that resource, and it's important in terms of advocating for better treatments and programs for the disease. And finally, we need more public campaigns that raise awareness of CD and help to counter misconceptions and reduce stigmatization and fear surrounding the disease. So what are some ingredients? Again, here's a picture. As I mentioned, Dr. Beatty's program in Florida. The University of Florida has a mobile outreach clinic. So this can help us provide testing in the community in places that feel safe, such as churches. Use of rapid tests can be a great tool because you can provide testing on the spot. You can get a fairly immediate indication of whether people need further testing. Right now, we only have one FDA-cleared rapid test in the United States. Integration of Chagas testing and treatment with other key primary healthcare needs, as I mentioned. Use of mobile clinics and telemedicine for certain situations. So there's an example of a program which was also focused on a migrant population in La Plata, Argentina, where telemedicine was successfully used, especially to connect with cardiologists and other specialists when needed. And considering bilateral collaborations. So for example, there was a collaboration between Bolivia and Barcelona, in which the Barcelona Institute of Public Health, as well as partners in Bolivia, were involved. And this was nice because when patients went back and forth between the two countries, it facilitated their linkage to care and their continuity of care in either. And so why couldn't we develop something like this, for example, between the United States and Central American countries? And now I will pass it back over to Elise.
Great, thank you. So to complement the examples of different methods that Colin has shared, I'll describe a little bit about what we do at Boston Medical Center to try to increase Chagas disease diagnosis and services within the context of existing primary care for refugees, immigrants, and migrants. So by way of context, Boston Medical Center is a large safety net hospital that serves a very diverse patient population. For a proxy of sort of country of origin outside the United States, 30% of our patients do not speak English as their first language. And naturally, all of the different departments and sections care for patients with who have different migration histories. And many of these departments have specific programs that are intended to serve the needs of those patients. But we also do have a dedicated immigrant and refugee health center that provides more specialized primary care services to immigrants and refugees. And through that program, there's central intake, more amplified case management services, and a special focus on screening for infectious diseases that affect these populations. And just one note to highlight as I shared this example, I think that I need to recognize that what we are able to do at Boston Medical Center is rather unique to being in Massachusetts, as we're able to provide medical care to patients regardless of immigration status through an insurance called Mass Health Limited. And so that's not the case in other states around the country. So our Chagas disease screening efforts are multifold, but starting with provider-focused education. And from that point, we've added on other initiatives. Our OB and midwife colleagues have added Chagas disease screening as part of routine prenatal screening for women who are from endemic areas. And we also have added in use of different EPIC EMR tools to try to facilitate the ease by which providers can order Chagas disease screening. And this all takes a team effort, including a number of colleagues and mentors within the infectious diseases section, Sarah Kimball, who runs the Immigrant and Refugee Health Center, and then a number of different sort of clinic champions from primary care clinics. So to start out with provider education, we took inspiration from the Strong Hearts program at East Boston Neighborhood Health Center, which started screening all their patients from endemic areas in 2017. We were seeing patients who were referred for Chagas disease care at BMC, but felt we were not doing enough in terms of screening our own patients for Chagas disease. And so in 2019, we started a program for basically sharing across many, many different venues information about Chagas disease to try to increase awareness and screening efforts, and have had these sessions in internal medicine, family medicine, pediatrics, various residency and other trainee conferences, and so forth. And these educational programs have since received additional support through the INSECT program, which stands for Implementing Novel Strategies for Education and Chagas Testing, which is supported by the CDC. And this additional support is also intended for sharing more broadly outside of our institution with various healthcare settings in New England and even farther afield, and to do qualitative research on the methods of dissemination that work the best. So in terms of the specific electronic medical record tools that we have implemented, we have created a rather simple screening order panel that is just intended to help a primary care provider or somebody who's seeing a newly arrived refugee, immigrant, or migrant to order the most important screening tests that should be performed. And on that, we have the T-Cruzy for patients who are from endemic areas. Second, we were able to work with our laboratory in order to create a process where, for confirmatory testing of patients who have a positive commercial antibody screen, that those patients do not have to come back for a second blood draw, but rather that there's a small aliquot of blood that's saved in the lab in case the screen is positive, and then there's reflex confirmatory testing out through the CDC. And so I think that really reduces the burden both on patients, most importantly, and then also on providers who are ordering this testing. And then finally, as I mentioned, the OB and midwives group, they have a very standardized prenatal testing panel, and they added Chagas disease screening to that panel for patients from endemic area. And so that quickly increased the number of individuals who are getting tested. These are just screenshots of the screening lab panel on the left, which is just sort of a menu selection of different lab orders. And then on the right, this is what it looks like within our electronic medical record to order Chagas disease screening. So it's easy to find and then easy to order. So through all of these various efforts, we have seen an increase in the number of tests that are being sent institution-wide. And our infectious disease clinic is seeing several new patients diagnosed with Chagas disease per week to get people connected and to care. And so I think in like 2020 and 2021 was when the midwives and OBs started their prenatal screening program. We started our education in 2019, but that has continued through 2023. And I think all of these efforts sort of complement each other in terms of getting the word out and then getting patients tested and connected to care. And so we'll pause again for another poll. The question here is, which is not necessary for a Chagas disease screening program within a primary care setting? So maybe we'll take one more minute. All right, can we show the poll results? All right, so yes, so this question, I was aiming for biosafety level 3 laboratory, which is not necessary to test the T. cruzi serologies. In terms of the first question, the first answer that many responded to, I think that it is, in my opinion, it is probably necessary to find a way to pay for these tests, either through patient's insurance, but if there's, if you're in a setting where most of the patients you are seeing do not have insurance, then I believe there are some examples of places where sort of like grants have been used to develop screening programs. But I think that that is one component of like making this actionable. All right, great, thank you.
In this last segment, what we wanted to talk about was kind of the current context of the global refugee crisis and what implications that might have for T. cruzi transmission and epidemiology. So just to kind of review in a very brief fashion what the global picture is for refugees and displaced people. So 100 million people estimated to be displaced worldwide, representing 1.2% of the world's population. And the causes of this are really identified as growing global political insecurity and instability is kind of the geopolitical structure that kept things relatively stable for many years after World War II is breaking down. We're also seeing an increase in repressive regimes, and also climate change is a big fuel of migration and displacement. Venezuela is a country where 7.7 million refugees and migrants have left. And how does that impact the United States? So 250,000 Venezuelans were reported to have crossed the US-Mexico border in 2023. Also estimated to be 1 million displaced Central Americans. And a lot of things are fueling migration out of Central America. A big one is violence and extortion, often linked to gangs, along with poverty and food insecurity. We're also seeing a social and political crisis in Haiti. And again, 146,000 crossings of Haitians reported at the US-Mexico border. And in Africa, 30 million displaced people, mostly from Republic of the Congo, the DRC, Ethiopia, Central African Republic, South Sudan, and Nigeria. And we're seeing other countries as well experiencing civil conflicts, human rights abuses, and lack of insecurity. And finally, the major wars that have triggered refugee crises in Ukraine and Syria. And what's interesting is that people from all of the countries that I've mentioned here have been reported crossing the US-Mexico border. So because it is so difficult to get into the United States through traditional pathways, people are being forced out of desperation to take very circuitous routes through Latin America in order to seek asylum at the US-Mexico border. I'm sorry, and this is just a graphic that kind of brings home, how that's been changing. So this is a report of extracontinental migrants at the US-Mexico border. And what we mean by extracontinental is people who've come from Asia or Africa or even Europe. And because the conventional channels are not open, they're taking routes through Latin America in order to get to the United States. And this was always present, but it was a fairly low number until sort of post-COVID. And you can see in the last couple of years, it's expanded pretty dramatically. And this is just an example. This is a report that looked at kind of the migration routes that African migrants were taking in order to go from Africa and to get into the United States. And this is a few years old, and so it's already a little bit outdated. But you can see the stars there showing the main entry points are Sao Paulo and Quito. And so they're taking a long journey across, through the Amazon in many cases, and then through the Darien Gap. And the difficulties of that crossing in Panama, have been in the news, and going all the way through Central America and Mexico in order to get to the border. A lot of people now are entering through Nicaragua to bypass the Darien Gap, but they still have a long route to go. So, what all this, just looking at the map, one of the questions that comes to mind when we're talking about Chagas disease is whether these long routes through endemic areas could pose a risk of exposure to T. cruzi. And why would we think that? Well, due to conditions, including, many times people are forcibly detained, oftentimes by smugglers as they await payments from family, or they're staying in border camps, waiting for authorization to cross borders. And so many of these extracontinental migrants and refugees are spending greater than 6 months in endemic areas. And so by that classification, they are already meeting our screening criteria for Chagas disease in the US. Then you could take into account as well that many are living in outdoor camps or in substandard housing, which could be susceptible to triatomine infestation, or sleeping outdoors during their journey in areas where triatomines are in the environment, or in some cases, possibly consuming food that would be contaminated by triatomines. And we don't have a lot of evidence right now. This is a pretty new phenomenon. So this is an area where I think more research is needed. It's also important just to point out that the migration routes are contributing to numerous deaths, illness, and injuries. And so T. cruzi is just another thing to add to that list. But a couple of years ago, and this was really through the initiative of Nelson Agudelo, who's an infectious disease doctor who's worked a lot on refugee health, and was also at the Darien Gap providing care to migrants. And so what we wanted to do here was address, well, what might be a potential algorithm for determining whether people who are not only refugees from within endemic countries, but coming from outside of endemic areas, might meet criteria for screening for T. cruzi. So I will end here with another poll question. Which of the following factors would not pose a potential risk of T. cruzi exposure to people from Asia, Africa, Europe, and the Caribbean on transcontinental migration routes? And I'll give you guys a minute. All right, great. It looks like most people are getting it. Yeah, so in this case, having lived in their home countries and housing made of natural materials, again, because the question is specifying people from outside of endemic countries, so they wouldn't have been exposed in their countries, but the A, B, and C all do represent potential risks during the migration route that could have exposed them to T. cruzi. Great, and now I will turn it back to Elise.
Great, thank you. Because of these recent events, we are seeing patients in clinic and in the hospital who have had very complex migration histories. And I think it means that our migration history, when interviewing the patient, really has to extend far deeper than where are you from, but also asking, where else have you lived in your life? How did you get here? What countries did you pass through on your way here? And what modes of transportation did you take during that journey? By way of example, I'm going to tell you about another patient who is seen in our clinic. She is a healthy 28-year-old woman from Haiti originally. And she had fled rising violence and economic instability in 2019 with her husband. She moved to Chile in 2019 for 3 months, and this is not uncommon amongst some of the patients that we see at Boston Medical Center. Went south to Chile, then moved to Sao Paulo, Brazil, where she lived for 3.5 years before starting a journey that took about 2 months that she took by bus and by foot. She started in Sao Paulo, then went west through Bolivia, north through Peru, Ecuador, Colombia, and then to Panama, where she passed the Darien Gap, which is a passage of jungle that takes 1 or 2 weeks of trekking to get through and is very dangerous for people. She went onwards through Costa Rica, Nicaragua, Honduras, Guatemala, Mexico, and Texas. And then by the end of 2022, she was able to get to her aunt's house in Massachusetts. And when she arrived, she was 37 weeks pregnant. She was seen in she was connected to OB care, and she had sort of standard prenatal infectious diseases screening, which is listed here. And then she also had T. cruzi screening, again, according to the general sense that individuals who have lived in an endemic region for over 6 months should have screening. And this screening and confirmatory testing returned positive for Chagas disease. She was then connected after fortunately giving birth to a healthy child. She was later seen in the infectious diseases clinic. And the plan was to initiate treatment once she is no longer breastfeeding. She is also referred to our Immigrant and Refugee Health Center for primary care. But she has had frequent phone contact with case managers and social workers from the Immigrant and Refugee Health Center. She has missed in-person primary care appointments. She's currently living with her husband and baby in a shelter that's about an hour and a half hours away from the hospital by public transportation. And so her story continues. And I think the larger story of the long-term health impacts of this treacherous and increasingly common journey that many people are taking to flee desperate situations continues. And there's concerns that Chagas disease may be part of that larger story, but more research needs to be done. So by way of recap for today's session, to remind you of the different segments of our talk, we started out talking about how Chagas disease is a neglected tropical disease that extends globally, and it's also neglected, unfortunately, in the United States. There are many barriers to care for people affected by Chagas disease, and they shape the full continuum from diagnosis to treatment. There are, however, multiple methods to improve access to testing and treatment that can be tailored according to the context. And finally, the current global crisis of displacement and also the common routes of migration carry new and poorly understood transmission risks. So that concludes our presentation, and thank you for the opportunity to share with you today. And I believe that we'll have some time for questions.
Thank you so much, Colin and Elise. This was great. I learned a lot, and I really appreciate your experience and sharing that with us. We would love to open it up for questions. Anyone or insight? I know there's also other experts that are here with us. If you want to share any of your thoughts about this topic, we are more than happy to open up the floor. You can also put it in the chat if you're feeling shy. Here we go. If screening in pregnancy, what do you do if positive? It's a great question.
Yeah, so we at the MC, we typically wrap around to our pediatric ID colleagues and try to organize cord blood for screening. And if it's, I guess, if the screening test returns during pregnancy, and to make sure that there's no congenital transmission. And otherwise, if that cannot be done, then the child has follow-up for screening afterwards with the pediatricians.
Thanks, Elise. We have another question. Is this a sexually transmitted disease?
That's an interesting question. Not as far as we know, no, but it is a fear that a lot of people have, when they're diagnosed. So it's good to reassure people after who have tested positive that no, it is not sexually transmitted.
Thanks, Colin. Another question, is there newborn screening testing available for newborns with maternal history who may not have been tested prenatally?
So I would have to double check on the exact timing of the recommended testing for the newborns, but I believe that the pediatricians do testing that you can do testing via PCR in the immediate short term prior to testing for antibodies later on.
Thank you. And also Sheila, who asked the question, last month we did a congenital Chagas transmission and peds talk, and we have both of those posted if you want to check back on those as well, because we had some really good, just like a full hour of descriptions about the procedures for that. Also, really quickly, and then I do see that there's somebody that has their hand up, but also Nancy says, have you reached out to cardiologists in the area to educate them in the area of Chagas? And that would be, maybe this would be across the United States, but in Boston, maybe in particular, I know we have definitely some experts from California, Dr. Shiva Mimandi and others, Dr. Rachel Marcus in DC, but just curious about your education, maybe at Boston with the cardiologist there.
Yes, we've had grand rounds with the cardiology section. And then there's a specific cardiologist that we work with named Deepa Gopal, who follows most of the Chagas disease patients that are followed in our infectious diseases clinic.
Thank you. And Cordella, you have your hand up. Thank you.
Oh, yes, thank you. I am intrigued with the suggestion to partner with endemic countries that you're having bilateral agreements. And I do understand that resources could be one of the barriers when partnering with endemic countries. But I think we could start with education. And one of the things that I understand with some of our developing countries is the population has a higher regard for public health. And and of course, they will have the culture brokers who are already on the ground, to share the information and, get people, informed and aware of what's going on. So I'd like to see more on how we could do that. So in having then another bilateral approach in that, addressing the issue there and here as well, as people, we've become such a fluid population these days, going back and forth. It could help.
Yeah, I think it's a wonderful idea that we have not yet taken advantage of at Boston Medical Center, but I think 85 or 90, at least 90% of our patients are from El Salvador. So I think that if we could develop bilateral communications and other initiatives with the regions in El Salvador that are seeing those patients before they come out, and also when they return for extended periods of time to be with family, that would be awesome.
I agree. Education would be a great starting point. Chagas disease is one of those diseases where a lot of the knowledge is still actually in the endemic countries. And so, for example, when we started new Chagas projects, sometimes we've sent doctors to Bolivia to train there because there's doctors who have so much experience already treating Chagas patients. So I think that could be a really rich area to establish some sort of bilateral collaboration.
Great question. Thank you. Also, I just was responding in the chat about Speakers Bureau available to give grand rounds on the topic. And I put my contact information in there also. Colin or Elise, I think we're pretty well connected to most all of the Chagas experts across the country, and we'd be more than happy to connect you with anyone who would like to do a grand rounds in their community for their providers. That'd be great. We'd be happy to. There are large influxes of immigrants coming from Texas and other places being sent across the country. So I think it'd be great to have those grand rounds in places where you're seeing a lot more immigrants coming. So feel free to reach out to me, or I also put the U.S. Chagas Disease Network, which is some of our colleagues in there, and we'd be more than, again, happy to connect people for you to have speakers as well. Any other thoughts or questions? This is a really important topic. As was mentioned, people living with Chagas disease could be scattered across the United States. I know we've seen in the blood donor screening maps, we see, Chagas disease popping up across the entire country, which that is obviously not necessarily from the population that we're most worried about or that we're talking about even today that are donating blood, but at the same time, it's still indicative of the fact that it's not just a problem in the southern states that we have to be worrying about this, but it's also healthcare providers across our country need to be thinking about where their population is coming from. And I really appreciate, Elise, your example of the woman from Haiti. As definitely I wouldn't be thinking about her being screened for Chagas disease, knowing what I know about where the disease is endemic, but having asked that question of where have you been before you got here is really critical and a very important topic and a question to ask about that travel history. So thank you for bringing that to light. Any other last minute thoughts? We're right at time. We'd love to, if you have any thoughts or questions, feel free to put them in the chat or chime in. We also have an evaluation. Don't forget to fill that out. And Kara, if you could just pop up the last slide for me, that would be great. This is the link to the evaluation. And if you are doing CME, CNE, or CEU for our community health workers, we do need you to fill out this evaluation and we'll get you your credits within a couple of weeks. And I think there's one more slide. And this is just, thank you for being here. If you do have questions, I put my email in the chat, but also the chagasus@gmail.com, go straight to me. And so feel free to ask any follow-up questions there or contact our speakers. These sessions are recorded. They will be up on the UT Health website, probably within a day or two. And then with the CDN website, we would love for you to direct your colleagues to watch as well if you want to recommend this for CME or CNE for them as well. And with that, I just want to thank our funders, thank the CDN network, my amazing colleagues at UT Health Echo, and all of our partners. And we will end the session here. And thank you for your time, for being here. And we'll hang on for a few more minutes if anybody has any remaining questions or thoughts they'd like to share. Otherwise, thank you for being here.